Hi, I'm Ashley Walton, ACR Director of Government Affairs. I'm going to discuss some of our key legislative priorities tonight, including physician payment and implementation of the No Surprises Act, legislation that would prevent surprise billing. I also will cover some issues that we're tracking in Congress, such as consultation of appropriate use criteria and graduate medical education. We know the current Medicare payment system is not sustainable. There are increasing costs associated with practicing medicine, and there's an overall lack of an inflationary update to the Medicare physician fee schedule. The cost of running medical practices have gone up by 47%, yet physician payments have declined 26% from 2001 to 2023. In 2014, Congress passed legislation known as MACRA, which was intended to shift from a volume-based care system to a value-based care system, but it's also had its challenges. With all of these factors at play, Congress has mitigated some of the cuts to the Medicare physician conversion factor since 2020. Yet additional action is still necessary. We need long-term payment reform to ensure stability, a permanent inflationary update. As I mentioned, Congress has passed legislation to mitigate cuts to the conversion factor, and at the end of last year, Advocacy by ACR helped mitigate some of these cuts. The college led a coalition of over 100 physician and non-physician providers, urging Congress to prevent the devastating cuts to physician payment. Medicare providers were facing a roughly 8.5% reimbursement reduction beginning in January of 2023. This included expiration of the one-year 3% congressional increase to the conversion factor for 2022 and a roughly 1.5% reduction due to the application of budget neutrality to fee schedule changes, and a 4% reduction to the application of budgetary pay-go rules. So Congress was able to add 2.5% to the Medicare conversion factor for 2023, 1.25% for 2024, and averted the 4% pay-go reduction for both 2023 and 2024. While this fell short of the full 8.5% adjustment that the ACR coalition requested, Congress did mitigate 6.5% of the potential reduction. ACR's coalition efforts actually resulted in a savings to radiology of $437 million for 2023. And in the last 3 years of fighting these scheduled cuts, it has saved the profession $1.637 billion. The Medicare trustees and MedPAC have called for legislative action to address the Medicare physician payment system by providing physicians with an annual inflation-based update tied to the Medicare Economic Index, also known as MEI. A March 2023 report from the Medicare trustees actually stated that they expect access to Medicare participating physicians to become a significant issue in the long term unless Congress takes steps to bolster the payment system. Luckily, a bill has been introduced in Congress to address the MEI update. H.R. 2474, or the Strengthening Medicare for Patients and Providers Act, was introduced by Representatives Ruiz, Bucshon, Barra, and Miller-Meeks as recent as April 6, 2023. This legislation does provide a permanent annual Medicare physician payment update tied to inflation as measured by MEI. So ACR will leverage grassroots and Hill Day participation to urge members of Congress to sponsor this legislation. Next, I'm going to discuss implementation of the No Surprises Act and ongoing challenges. I'll provide an overview of the legislation, status on some of the lawsuits, and talk about some of our advocacy efforts. The No Surprises Act, or the NSA, was legislation passed in 2020 that took patients out of the middle of payment disputes when receiving care from out-of-network providers. It established an independent dispute resolution, or an IDR process, for resolving payment disputes between providers and insurers. This resulted in several rules issued by government agencies to govern the IDR process. This includes the Departments of Health and Human Services, Labor, and Treasury as the implementing federal agencies. So as this was unfolding, the medical community quickly realized that the rules governing the IDR process did not align with the legislation that Congress passed. In turn, we brought several legal challenges questioning key aspects of these rules, notably the qualified payment amount, or the QPA, increase in administrative fees for the IDR process, and barriers around batching claims. So I'll provide some additional details coming up on those lawsuits and the different challenges related to the IDR rules. Some of the specific challenges surrounding the NSA regulations include the QPA, increased administrative fees, and barriers around batching. So the NSA directs the arbiter to consider all information submitted by the physician and insurer, including the median in-network rate, complexity of the case, previously contracted rates, and market power of the physician and insurance company, among several other factors. So the legislation intended that the QPA could be one of many equally weighted factors. However, in reality, the regulations actually made the QPA the primary factor in the IDR process. This truly set an artificially low benchmark for payment. It's led to insurance companies pushing physicians out of network, narrowing provider networks, and a reduction in access to care. Last December, an amendment to the IDR fee guidance was also announced, raising the $50 administrative fee, which was set earlier in the year in October, to $350. The administrative fee is charged to each party at the beginning of the IDR process. This is in addition to the fee charged by the IDR entities, ranging anywhere from $200 to $700 for a single claim determination, and $268 to $938 for batches or groups of similar claims. So each party pays the IDR entity fee, and then it's refunded to the winning party. Yet this new administrative fee that was raised from $50 to $350 is not refunded to either party. So given the fact that most radiology claims are for far less than the $350, this actually amounts to a 600% administrative fee increase that makes the process prohibitive for radiologists. So the costs are so high that for most radiologists, it's not even worth going through this IDR process. Because of the problematic regulations, several lawsuits have been brought by the medical community. This began with the Texas Medical Association, the American Medical Association, and the American Hospital Association, as well as ACR, along with the American Society of Anesthesiologists and the American Colleges of Emergency Physicians. The original ACR lawsuit and similar lawsuits by the TMA, AMA, and AHA focused on the specific IDR language issued in the interim final rule by the implementing federal agencies. However, the TMA suit got the first decision. A judge ruled that the federal government acted improperly and invalidated the IDR provisions. So then the government withdrew the IDR language and issued a new final rule with new IDR provisions. However, the medical community also agreed that this new language was not valid and still misapplied the qualifying payment amount. So, come October 2022, ACR submitted an amicus brief, or friend of the court, in a second NSA lawsuit, along with the Texas Medical Association suit. This is what we've been referring to as TMA2. So ACR, ASA, and ASAP withdrew our separate suit and joined TMA2 with the TMA. I'd also note that additional lawsuits have been filed challenging the IDR fee hike and the batching process. So we've been calling these TMA3 and TMA4. So I'll provide some additional details on those a little bit later. There have been some recent updates to the lawsuits on implementation of the No Surprises Act. In February, a federal court actually invalidated parts of the NSA regulations regarding the IDR process. The court said that the regulations unlawfully placed a thumb on the scale for the controversial QPA over other factors arbiters must consider. The government had then instructed arbiters to hold payment decisions until it issued further guidance to comply with the court's decision. Yet recently, the government did update its guidance for the IDR process and instructed IDR entities to resume issuing payment determinations. So the new guidance is an improvement and instructs the IDR entities to consider both the QPA and additional information related to the offers submitted by the parties. The guidelines also instruct the IDR entities to provide an explanation of the rationale for its decision, including what information was used to select the offer that best represents the value of the qualified IDR item or services. So the weight given to the QPA and any additional information submitted has to be provided as part of that explanation. So this recent February decision was, welcome to the medical community. ACR was very pleased. However, the federal government has announced its intent to appeal the decision. So we're currently awaiting the legal process to unfold, both with that TMA 2 suit as well as TMA 3 and 4. But to provide an update on the suits related to the fees and the batching process, oral arguments have been set for April 19th. So a decision will follow that. So where that leaves us now, we're awaiting the court decisions. We'll continue to partner with others in the medical community as well as work with Congress to ensure that the administration implements the law as it was passed. So as a reminder, this means equal playing field for both providers and insurers to resolve their payment disputes while taking patients out of the middle. So I'm going to shift the focus a little bit. To conclude my presentation, I'll highlight two other key issues that the ACR is tracking and actively engaging Congress on: consultation of appropriate use criteria, and then support for additional graduate medical education slots. The Protecting Access to Medicare Act, or PAMA, was passed in 2014 and mandated the consultation of appropriate use criteria, AUC, by providers ordering advanced medical imaging exams. So although PAMA called for the AUC program to be implemented in 2017, several regulatory delays have been issued throughout the years. The most recent update was that the program was set to begin and implemented in January of 2022, but further delays have held up the program. So where that leaves us is ACR is working to ensure that the program is carried out as intended. We've met with some of our congressional allies on both the House and Senate side and have engaged some of the key agencies such as CMS to ensure that the program is implemented. Next, with physician shortages persisting, ACR has urged Congress to ensure additional graduate medical education slots are created. There is legislation introduced in the House of Representatives that we support. The Physician Shortage Reduction Act would expand the number of Medicare-supported medical residency positions by 14,000 over 7 years. So this legislation has been introduced in previous Congresses, and we do continue to advocate for the introduction of new slots to address some of the problems related to physician shortages. So that would conclude my presentation. If you have any questions, please do not hesitate to reach out.
My name is Eugenia Brandt. I'm ACR's main liaison for state affairs, and this evening we're going to do a quick update about state legislative activity. Of course, it's April, which means we're in the middle of legislative sessions for many of the states, and all states will meet or already have met in 2023, and many of them are still meeting. 3 states have adjourned. And as always, throughout the year, please reach out to us with any specific questions. We're happy to meet you and answer any concerns or questions that you may have. I wanted to do a quick overview of the types of services we offer. Of course, we work very closely with our state chapters and especially state chapter leaders. About half of our chapters have a lobbyist, whom we call boots on the ground in their states, especially in the states where there's a lot of proactive legislative activity. If you're trying to pass a bill, you most often need the help of a professional lobbyist. And several of our chapters work very closely with the state medical society, the state AMA lobbyist, if they have a good relationship, or if it's a situation where they're not necessarily trying to pass legislation, they're just trying to be proactive about monitoring what's happening in their states. Those kinds of relationships work really well. We do track bills in all 50 states. There are reports from Fiscal Note that go out with email alerts to the state chapter leaders. If you're interested in receiving a report, a weekly report for your state, please let us know. I know some of you are probably thinking, I don't need another email, and that's fine. The information is also available on our website at acr.org. The types of advice we can offer from the GR office in DC is strategy. We're also a repository of knowledge. We can tell you some historical context. We can also fill you in on what's happening in other states. Sometimes you may be asked to present in your state or maybe your former institution or university, and we're happy to prepare a couple of slides for you that would be more recent. I always have a disclaimer that because the states are still in session, the information we give you today is going to be up to date as of today. So always kind of reach out and ask us if anything has changed since the last time we spoke, because things do happen very quickly. We do review model and legislative language. It's often easy to make changes when the legislation is still in the draft form. We are happy to liaison with other specialties, make introductions with the state medical societies or your RBMA chapters. We do have a state government relations committee. It's currently chaired by Dr. Bonnie Litvak of New York. It's an excellent soundboard for any questions that you may have. You can hear from your peers about their experience. And of course, we work very closely with RAN and our grassroots, and we are kind of involved in the every step of legislative process, pre when you file legislation, throughout the process, when amendments are filed, when things are passed into law, there's always or often is a regulatory rulemaking, and we're often monitoring throughout the lifespan of the bill, because in the following year there may be efforts to undo the good work that has been done in years past. So it's sort of a rinse and repeat cycle that we go through. So many issues. I know some of you are familiar with our federal issues. There's a lot of scope of non-physician personnel that is regulated at the state level. There's certificate of need. There are always efforts to dismantle certificate of need. Radiology tends to be one of the only specialties that favors keeping the certificate of need in place. There's telelicensure issues, breast health issues, and by that I mean breast density reporting, diagnostic workup priority, supplemental imaging, such as MRI and ultrasound, tomo coverage, Medicaid coverage. There are out-of-network issues for states regulate some health plans at the state level. So state pension, employee health care plans, they're regulated at the state level. Of course, the ERISA plans, the self-insured plans, are not self-funded plans, are not subject to state regulations, but about 30% of the plans are. So there's a lot of insurance issues that are actually worked out at the state level. There are network adequacy bills. So it's a very busy, very exciting time for us. New Mexico was already able to wrap up their session, and they had some success with passing diagnostic workup bill for following a screening mammogram. We're very excited about that. Things are things are always happening at the state level. If you have specific questions, please reach out. I do want to highlight the opportunity of getting involved with your state chapter. It's going to be the best resource for you, especially if you're just getting involved. You can shadow one of the leaders, you can get involved with your state legislative chair if you have one in the state, or if your chapter is not very involved or very active, I would say getting involved with the state medical society's chapter is often the way to go. And if you're interested in making introductions, please reach out to us, and we're happy to facilitate that for you. A lot of activity at the state level centers around scope of practice, and this year is no different. I have included a link on this slide and also our contact information. When I say we house a lot of information about the bills we track on acr.org, it's all of the bills we track. There's literally hundreds of bills that are in play right now, and I'm going to let Dylan fill you in on what's happening with the scope of practice of non-physician personnel at the state level. Thank you.
Well, good evening, everyone. My name is Dylan Harp. I am a senior state government relations specialist at ACR. I am going to take a few minutes of your time tonight, mostly talking about scope of practice and scope of practice activity, including our SOP grant. And then towards the end, I'll take just a few moments to briefly mention an exciting advocacy presentation and opportunity that we have for our members and for our members in our state societies. So I briefly wanted to start off with, as you can see on this first slide, talking about some of the 2023 scope of practice activity that we've tracked so far this year. Currently, we've been tracking a little over 85 plus pieces of legislation in 38 different states. Most of these 85 plus bills are kind of going to be more of the generic scope of practice legislation that you're familiar with, dealing with mid-levels wanting partial or full independent practice. But of course, those could have a direct impact on radiology and on your practice and on your profession. So that's something that we're actively always engaged in monitoring in and coordinating any type of efforts and information that we have with the various state radiological societies. There have been a fairly decent handful of scope of practice related legislation that has been very specific to radiology, which I'll get into in a little bit. But as you can see on this first slide, the very first QR code, if you're able to scan that with your smartphone or with your smart device, it will take you to my master Excel spreadsheet that will go through all the scope of practice bills that we have been tracking so far. I also wanted to mention, you'll see on this slide as well, the second QR code, if you scan it, it will bring you to our scope of practice microsite. This web page has tons of great information about the SOP grant, which I'll get into in just a little bit. But it also has a lot of information about different sign-on letters that we've done, different organizations that we've partnered sign-on letters with, and just overall some great scope of practice activity. Okay, so drilling down a little bit more on scope of practice and really focusing on some scope of practice bills that are unique to radiology. It seems about every year we start to see some slight different twists and turns on the scope of practice landscape. So, but especially this year, we've started to see some scope of practice bills dealing with that would allow physical therapists to either refer and or order diagnostic imaging services. Currently, we're seeing bills in Iowa, New Mexico, and Rhode Island that would allow a physical therapist to do this. So obviously, this is something that we've been very forceful advocating against and working with the various state radiological societies on advocating against these bills as well. But now, before I kind of wrap up my presentation here in the next few minutes, I did want to leave us with a little bit of good news. On those physical therapists ordering and referring, we've gotten some pretty good results so far. So in New Mexico, there was a Senate bill. It was Senate Bill 412. This bill would have permitted physical therapists to order MRIs to aid them in the diagnosis and treatment for their patients. That bill failed to get out of the committees of jurisdiction that the bill was assigned to. The New Mexico state legislative session has ended for the year, so effectively Senate Bill 412 is dead, and it could not be reintroduced until their next legislative cycle. Sticking on the physical therapist ordering mindset, I also wanted to mention there was another bill in Rhode Island. This was House Bill 5013. This bill would have extended a sunset provision. So to backtrack just briefly, last year in Rhode Island, they passed a bill that, again, is set to sunset or to end at the end of this year that allows physical therapists to order diagnostic imaging. So there was another bill in this current session that would have extended that provision until December 31st of 2025. That bill has been in Rhode Island. They've called it in the committee that it's been held for further study. Essentially, that means that the bill has been held indefinitely. Although theoretically it could be brought up, it would be highly, highly unlikely. So that is essentially a win for us, and that bill will be dead in Rhode Island this year. And then finally, switching topics off the physical therapy ordering, but still very radiology specific. There were two bills in Oklahoma, and this was House Bill 2168 and Senate Bill 958. Both of these bills would have allowed certified registered nurse anesthetists who hold a certification in non-surgical pain management to perform fluoroscopy. I was actually in Oklahoma a few weeks ago, participating with some of our members at the Oklahoma State Medical Society State Advocacy Day. I was able to speak with the Oklahoma chapter's lobbyists, and it seems like both the House and Senate bill have been kind of hamstrung in their committees, and they do not seem like they will be moving forward either. So that's very good. So very briefly, I just wanted to let everyone know, if you've not heard about the ACRA Scope of Practice Grant, This is a grant that was created in 2021, and this grant is open to all state radiological chapters. It's funding that's available that states can apply for through a grant process to help them battle and advocate against harmful non-physician scope of practice expansion legislation in their state. So far this year, we've awarded 4 grants to 4 different chapters, and that is to Michigan, New Jersey, Oklahoma, and Texas for a total of $67,000. And finally, I wanted to briefly touch on kind of an exciting advocacy opportunity. So last year, we started a virtual resident advocacy 101 presentation. And again, these are all done virtually to where ideally myself and then someone, a chapter leader from that respective state chapter, we will speak virtually to residents about ways that they can get involved. It's great when the physician is able to talk about their experience in advocacy as well. I won't get into all of it right now, but if you do have any questions or if you're interested in it, please reach out directly from me. This presentation series that we did last year was a great success. We hit about 9 different radiology residency programs, 1 in New York, and we hit 8 of the 9 in Texas. And we were able to reach and speak to over 154 residents. So if it's something that you're interested in, please let me know. And then finally, before I wrap up, there's a QR code on this slide as well. If you would like to scan it, you will be able to hear from Dr. Sarah Avery, who is the former president of the Texas Radiological Society. She joined me and we spoke to 8 different residency programs throughout her state about the importance of advocacy, and it was a great success. Again, if you have any more questions, please feel free to reach out to me. Thanks.
Hi, my name is Katie Grady. I'm a Government Affairs Director at the ACR Government Relations Office in Washington, D.C. I will be telling you about why working with the executive branch of government and the related federal agencies, specifically to research policy, is a key part of ACR's advocacy and representing the interests of ACR members. I would like to note that I have no financial relationships to disclose. This is the ACR GR Regulatory Affairs team. The team is overseen by Gloria Romanelli, who is the Senior Director of Regulatory Affairs and Legal Counsel to the Quality and Safety Operations of the College. Michael Peters is a Senior Government Affairs Director who covers many regulatory issues, including the Nuclear Regulatory Commission and the Food and Drug Administration and more, and myself. This graphic provides a quick overview of all the federal agencies ACR interacts with. These agencies provide a variety of purposes, including rulemaking, providing guidance, establishing new programs. Topics we cover included residency slots, artificial intelligence and machine learning, radiation, radioactive materials, funding, and much more. I am here today to talk about research policy, specifically diving into the National Institutes of Health, NIH, and a new agency, the Advanced Research Projects Agency for Health, ARPA-H. This slide provides an overview of some of the research agencies American College of Radiology works with to ensure radiology and imaging are represented. The National Institutes of Health. The NIH is the largest public funder of biomedical and behavioral research in the world. There are 27 institutes and centers of the National Institutes of Health, some of which tie directly to radiology and imaging, such as the National Cancer Institute, NCI, the National Institute of Biomedical Imaging and Bioengineering, NIBIB, and the National Center for Advancing Translational Sciences, NCATS. One of the advocacy focuses for ACR is, and specifically what I cover, is to strengthen relationships with key NIH offices, communicate new initiatives and funding opportunities to the ACR membership, and work with coalition partners to advocate for increased funding to NIH. As I mentioned, the NIH is the largest public funder of biomedical and behavioral research, hence it maintains a very large budget. The current fiscal year 2023 budget is $47.5 billion, and this year the research community is advocating for $50.9 billion for the NIH base level in fiscal year 2024. This would be a total increase of $3.5 billion. The President's budget released in early March included $48.6 billion in discretionary and mandatory resources for NIH, an increase of $920 million or 1.7%. Related to radiology and included in the overall NIH increase, the President seeks a $500 million increase in funding for the NCI including research towards prevention, diagnosis and treatment efforts, and approaches in cancer research, which rely on radiology and imaging tools. I also wanted to note that the National Institutes of Health has largely received support from both sides of the aisle and has received 8 years of consecutive funding increases. We hope that Congress will include a substantial increase for the National Institutes of Health for fiscal year 2024, including a consistent increase among the 27 institutes and centers to ensure development and progress in basic biomedical research is continued. As previously mentioned, ARPA-H is a newly established agency that was proposed by President Biden to improve the government's ability to speed biomedical and health research. Based on the Defense Advanced Research Projects Agency, DARPA, ARPA-H's mission is to create breakthrough health technologies as well as balance long-term scientific challenges with short-term research goals. ARPA-H is included as an agency under the Health and Human Services Department. ARPA-H will not offer research grants, but they will provide cooperative agreements and contracts. All research will be focused on the proposals overseen by the program managers, whose term will last 3 to 6 years. The projects ARPA-H will take on will be high risk and not suitable for funding through any other agency. From the President's 2024 budget, ARPA-H was proposed to be funded at $2.5 billion. The biomedical research community continues to reiterate that funds for ARPA-H should supplement rather than supplant NIH's core investments in basic research. ARPA-H's initial focus is on cancer and other diseases such as diabetes and Alzheimer's. And March was the 1-year anniversary of the establishment of ARPA-H. Recently, an open, broad agency announcement was released seeking funding proposal for research aiming to improve health outcomes across patient populations, communities, diseases, and health conditions. This announcement was really exciting to see, released on the 1-year anniversary, as it shows development and progress within the agency. Reauthorization of the 21st Century Cancer Moonshot. The Biden administration has repeatedly made it known that ending cancer as we know it and significantly cutting cancer deaths is a priority. In the president's budget, there was language included to reauthorize the Cancer Moonshot program, including more than $2.9 billion in funding for the program. The original Cancer Moonshot funding, which was established in 2016, runs out this year, so reauthorization for this initiative would be necessary for any additional direct funding efforts. The Cancer Moonshot is a cross-agency goal and program. Funding for the Cancer Moonshot was also incorporated into the proposed budgets for the U.S. Department of Health and Human Services and specific agencies including the Food and Drug Administration, the Centers for Disease Control and Prevention, Indian Health Services, and Health Resources Services Administration. Thank you for listening and joining the webinar. To stay up to date with government relations news, including some of what I reviewed today, I would recommend subscribing to the ACR's Advocacy and Action newsletter. Weekly, we share news, events, new publications, funding opportunities, and more happening at federal agencies, as well as major developments and actions and any comments released by ACR related to advocacy and government relations issues. Thank you.
Hi everyone, my name is Haley Brown. I am a Government Affairs Specialist here at the American College of Radiology. My presentation this evening is called RADPAC, a Peek Behind the Curtain. My goal for this presentation is to offer a little bit of transparency and insight into RADPAC and what we do. For some background information, prior to coming to the American College of Radiology, I was actually a PAC fundraiser here in DC. That means that I was raising money for members of Congress from the PACs that exist here in DC. So with that, and plus coming here to RADPAC, I feel like I can offer a little bit of insight into how this process works from having done both sides. So hopefully you find this presentation beneficial. This first slide you're going to see is the impact of that RADPAC had in the 2021-2022 election cycle. You can see that between 2021 and 2022, we raised $1,875,000 in hard money contributions. And obviously, in turn, we dispersed $855,000. And you can also see on this slide that I have the independent expenditures. If you are not familiar with what an independent expenditure, this is a way for our PAC to continue to support candidates and our champions in a way that is in addition to the contributions that we have already given to their campaign committees. The FEC regulates how much a PAC is able to give to a campaign committee in any year. So by doing an independent expenditure, it kind of gives us an opportunity and an avenue to support them in addition to that. The way this works is we will work with a vendor, whether that be a digital vendor, a TV vendor, a mail piece vendor, and we will create an ad in support of this candidate with absolutely zero coordination with the campaign. So it's completely separate of the campaign. We do it all on our own. And so you can see we were able to do $471,000 in independent expenditures. And this is just really a great opportunity for us to show a campaign that we're really supporting them and we're really rooting for them and using our resources to the best of our ability. So our election success, obviously you can see that we had a great track record in this last election. We supported 130 House candidates and 121 of those candidates won their race, which was a 93% success rate. All 20 Senate candidates that we supported won their election with, so obviously 100% success rate. So you can see that not only is RADPAC supporting candidates who we think are going to be our best champions in Congress, we're also supporting those candidates who are the most viable. So we're not going to throw our money at candidates who we don't think have a chance to either win their reelection or, if they're a first-time candidate, win for the first time. We're really going after those candidates who we think have the most viable chance of winning. So the way that this cycle works and the PAC process, when RADPAC receives a hard money contribution from you, whether that be a direct contribution online, a check in the mail, or if your practice sends us a wire of a payroll deduction, it's still attributed to you. So that is a hard money contribution. We will then in turn disperse that money to a campaign committee of a member of Congress who we would like to support. With this contribution, we are able to send one of our ACR Government Affairs staff members to meet with that member of Congress and their staff at a fundraising event. So this is not an official business. It's not a congressional business event. This is a fundraising event. And so we attend those events with other MADPAC groups. MADPAC stands for Medical and Dental PAC Group. So it's really a group where we're all in the medical association specialty group. And so by doing this way, we're able to attend events with those who have interests that are similar to ours, which really helps with the event and the staying on topic at the events. Like I said, we had quite an impact in the last election with our hard money contributions. So with those, we were able to attend over 80 fundraising events in 2022. We expect when we get closer to a presidential election year that will increase somewhere to 150 events. And just for a little bit more insight and for your awareness, when we send a staff member to one of these fundraising events, the average get in the door price is going to be $1,000 to $1,500 contribution per event. And so really all of your contributions are making an impact, because the more that you're contributing to RADPAC, obviously the more events we are able to attend, the more interactions we are able to have with these members of Congress. So MADPAC, like I alluded to earlier, is the medical and dental PAC groups. It's comprised of about 40 different medical and dental specialty association PACs here in DC. This group is really very niche, and not any of the other industries have anything similar to this. It's really a very collaborative and cohesive group that exists. We work together, we share information, and we do a lot of different events together. And one thing that MADPAC does quarterly is a MADPAC draft. And so you can see there on the screen, I've got the pick is in picture for the draft. We meet quarterly, and every group who attends the event will get assigned a draft number. Just pick a number out of a hat. And when it is your turn, you are able to select a member of Congress that you would like to host the fundraising event for that quarter. And obviously everyone else in MADPAC is able to join your event. Like I said, it's usually $1,000, $1,500 to get into the event. But by hosting it, you're going to have top billing for the event. The member of Congress is going to know that you were the host for the event. You put in the work to help raise the money for them. The other reason we do this draft is so that not every group is supporting the same member of Congress. We're able to pool our resources better this way and obviously work together. And so there's not going to be multiple events for the same member when we can all do one event and all attend and get the best ROI for everyone. The other things that MADPAC does is we do a MADPAC forum, which is a weekend that we bring PAC staffers and PAC board members from every PAC together to kind of share ideas, which fundraising tactics are working, what strategies have we found work best, what's not working. And like I said, the really cool thing about this group is we're all kind of doing something similar for our physicians. And so if a fundraising strategy is working well for another group, maybe it'll work for us. So we're not really competing for the same set of donors, which is very helpful for everyone in the group. And it works out really well because we can see, oh, this didn't work for them, we're not going to try it. So it's definitely very helpful. The picture on the right you can see is from a MADPAC forum last summer in Louisville, Kentucky. We were privileged enough to bring Dr. Amy Patel, and she's standing there next to Congressman Brett Guthrie, who was also able to come up for a reception that evening. So like I said, a great weekend of programming, information sharing, and networking. The other event that we offer as MADPAC is the MADPAC Candidate Workshop. And this weekend, or it's not a full weekend, just one day, is available for any physician within the MADPAC groups that is interested in a run for office, either imminently or sometime in the future. This is an opportunity for us to share resources, hear from past physicians who have ran campaigns, hear from fundraisers, how to set up your Rolodex if you want to run, etc. So it's really a great weekend of resources and more information if you're ever interested in running for any office. This is a chart of how RADPAC ranks among MADPAC. So as you can see, we are currently number 4 in terms of hard dollars raised in 2022 with our 968,418. Obviously, we would love to break the top 3. I think we might give the dentists a run for their money this year. You can see the anesthesiologists are really, really the gold standard when it comes to PAC fundraising, but us being number 4 gives us some huge clout on Capitol Hill. People know who we are. We're able to play in more races. We're able to have a higher impact. And so really being in the top 4 is something top 5 at least, is something we should all definitely be proud of. And we're really hoping that maybe we can move up to 3, hopefully this year. So this next slide is on disbursements and who we are supporting as a PAC. I think it's really important to acknowledge that RADPAC is a nonpartisan PAC. This is somewhat new branding. We used to call ourselves bipartisan, but we felt like in such a divisive political climate, it was almost better to call ourselves nonpartisan, because we are going to support Democrats and Republicans. And at the end of the day, the PAC, we are a radiology PAC, meaning we are going to support pro-radiology candidates. Obviously, every member of Congress, every candidate running for Congress for the first time, are going to have a slew of issues. But at the end of the day, all we care about is going to be whether they are pro-radiology and whether they are going to help advance the advocacy agenda of the college. So oftentimes that means we're going to support those members of Congress who are on the committees that are most germane to our issues. In the House, that is usually going to be Ways and Means and Energy and Commerce. And in the Senate, it's most likely going to be Senate Finance and Senate Health. We also usually support leadership because they are the ones who are going to bring the legislation to the floor. So it's great that we have relationships with these members of Congress and with these senators on the committees, as well as those outside of those committees who we have excellent relationships with. I mean, it's no secret that in DC, if you have a relationship with someone, it's going to help you get more time in front of them. It's going to help you be able to educate them more on our issues, advocate for our issues, etc. So that's really what we kind of focus on in terms of who we are supporting. And I also would be remiss if I didn't mention that in an effort of transparency, every contribution that RADPAC sends out is going to be public knowledge. So fec.gov, if you type in American College of Radiology Association PAC, you will be able to see all of our disbursements, because we're really not trying to keep this a secret. Like I said, it's public knowledge. So it's really open to everyone. And that's the end of my presentation. If you have any questions, you can email me at hbrown@acra.org or put it in the chat on the Zoom.
My name is Melody Ballesteros. I'm Assistant Director of Government Affairs and Executive Director of the Radiology Advocacy Network, also known as RAN. The RAN is made up of a great group of radiologist volunteers and super advocates. Our RAN board is chaired by Dr. Amy Patel, who also chairs RADPAC. Her goal is to incorporate all aspects of advocacy into one cohesive group. The RAN has been hard at work over the last 12 months. Today, I will update you on what we have been working on and why we need your support and involvement. The Pre-Radiology RAN is the dedicated advocacy group that is specifically for medical students seeking radiology as a specialty. The two founders who deserve all the credit are Woodland Daniel and Ryan Morrison. Woodland Daniel, a fourth-year medical student at Hofstra University from New York, will start her diagnostic radiology and residency at the University of Pennsylvania. Ryan Morrison, a fourth-year medical student at Rowan University from Virginia, will start his diagnostic radiology residency at Georgetown University. I encourage you to read the article highlighting their contributions to creating this group found in the QR code. Woodland and Ryan created and recruited a robust group of medical students who are ready to continue the work they started. Meet our 2023 to 2024 Pre-Radiology RAN Committee, and congratulations to them for being selected for these important roles. In addition to creating a dedicated group to continue the program, Woodland and Ryan have provided the following resources to medical students showing an interest in advocacy: regional reps throughout the country, medical student-led presentations on issues affecting radiology and its patients that range from scope of practice, Medicare cuts, insurance coverage, gold carding, and many others. If you have an interest in getting involved, please use the QR code to access more information. Another exciting program we are pleased to introduce is the Radvocate Leader Certificate. This program is intended for ACR members interested in strengthening their understanding and expertise in critical components of advocacy. To complete the program, members must earn 20 credits within 2 years of registration by completing these programs and criteria from all aspects of government relations. Upon completion, members will be recognized at the ACR annual meeting. If you are interested, please use the QR code on this slide to get more information or to register for the program. Our goal is to continue to grow RAN in a way that benefits and expands grassroots and grasstops across federal and state levels. However, we can't accomplish or increase our advocacy outreach without your support and action. So here is why we need your support. Only 6% of Congress has a healthcare background. This means that when you interact with your legislators, you are the expert on healthcare and what your patients need and deserve. This small sampling of issues are another reason we need your support and voice to amplify the need for comprehensive and equitable healthcare. As you can see, these issues range from issues that affect our patients directly to issues that affect them sometimes indirectly. How can you get involved? Join the RAN. It's the most effective and comprehensive way to stay involved. Please respond to calls to action, both from the federal and the state levels. Start early. For those of you who are medical students and residents, this is the best time to get involved, but it's never too late. Lastly, participate in everything and all things advocacy related, whether it's town halls, the Hill Day at the annual meeting, or participate in Radvocacy journal clubs and Radvocacy webinars. Other ways to stay involved are to follow us through our social media. Below are listed all the hashtags and the ACR RAN Twitter handle. So in conclusion, advocacy represents your commitment to the future of your profession, which you control. Make advocacy automatic. No wiser words have been said. Thank you, Dr. Silva. If you're not at the table, you're on the menu. And there are diverse opportunities to get involved in the RAN. We need advocates from all practice types to ensure the success of radiology. The earlier one gets involved, the better. Thank you again for joining us, and thank you for participating in this webinar.